from the UK, and it's my pleasure to welcome you to session 2 of the first International Symposium on Digital Health, or the first virtual symposium. For those of you joining again, welcome back, and those joining new, welcome too. I'm Dr. Michelle Morris, Academic Fellow from the University of Leeds and Fellow of the Alan Turing Institute. I was facilitator with Dr. Esther Talbom for the first session 6 hours ago. And I have a quick roundup of the excellent first session where we had 5 fascinating talks. Our keynote speaker, Dr. Ashley McKim, Editor-in-Chief of the BMJ Innovation, spoke about digital innovations from the COVID pandemic and the ones that will make the biggest impact in 10 years' time. There were 4 key areas of innovations that he believed will make the greatest impact. The rapid vaccine development, that had seen a decade shift in timeframes, remote healthcare adoption, AI for disease prediction, and the impact of social media, both in good and bad ways. The key challenges that he believes will remain post-COVID include the exacerbation of health inequalities, concerns and challenges relating to data security and privacy, and the lack of comparative studies for telemedicine. We moved on to hear from Professor Bjorn Schuller from Imperial College London about mobile digital health innovations and how these have been used in many forms of monitoring during the pandemic, from risk assessment through diagnosis to managing the spread. Audio-based artificial intelligence tools have been developed to diagnose COVID from the sound of your cough, and in some cases so sophisticated that audio tools can be used to identify asymptomatic patients from their speech. That blew my mind. Professor Anthony Smith from the University of Queensland reminded us that telehealth is in fact not new, but the pandemic has really brought it to the fore, driving healthcare to catch up with other industries with respect to digital applications. We really need to build on the momentum of this with respect to innovation the pandemic has brought and develop a skilled workforce in digital health, empower consumers or our patients, improve digital ecosystems, and make sure it is integrated into routine practice. Professor Jonathan Chian from Stanford University introduced the idea of 3 tiers of consultation that should be brought in as standard. And anyone online from the UK, these are simpler and clearer than the 3 tiers that we're currently experiencing with lockdown. These are an in-person consultation, an electronic consultation, which could be as simple as an email with your clinician, and an automated consultation that utilises data-driven AI methods. All of these have a place in healthcare. We cannot replace clinicians, but there are tools that can help them and help guide them to providing the best care for patients. And finally, Professor Dean Ho from the University of Singapore talked to us about drug development and the development of drug dosing regimes to better suit a patient using N of 1 healthcare, where only the patient's data is used to inform the future patient care. This can enable dynamic dosing and better results for the patient with less side effects from drug toxicity in certain cases. So as an example, where patients are on a combination of 12 drugs with 10 potential different doses, this is 1 trillion possible combinations. So using computer algorithms here are beneficial to finding the best personalised combination for the patient. The panel session raised really important discussions, including that AI doesn't have to be expensive as it can take many forms, the importance of balancing clinical safety against the speed of AI, and there are still concerns over whether we can really trust algorithms, even though we trust our doctors. The overarching message from the session is that while there's been an incredible amount of tragedy that COVID has brought globally, there have been paradigm-shifting innovations in digital health, which we need to make sure remain post-COVID. Personally, I really enjoyed the session, and I encourage those of you who missed it to catch up later. You won't be disappointed. And now I'll hand over to my colleague, Professor Bryant Lynn, for another fantastic lineup of speakers.
Great. Thank you so much, Dr. Morris. Really fantastic work leading the first session and an excellent recap. I'd like to welcome you to the session 2 of the International Symposium of Digital Health that is for the year 2020, virtually online. We have a fantastic lineup today, and we will hopefully have a equally fantastic and discussion and Q&A at the end of the session, and then we'll wrap up with some closing remarks. I am pleased to introduce my friend and colleague, Afsana Akhter. Afsana she is the Chief Growth Officer at Kio. Afsana has over 20 years of experience across tech and digital health and has helped commercialize several innovative digital health products in the US. She is currently the Chief Growth Officer of Kio, which provides a digital therapeutic for musculoskeletal conditions. Musculoskeletal conditions are a top cost driver for US employers and a leading cause for opioid use. Prior to Kio, Afsana was the Chief Commercial Officer at Prealize Health, a Stanford spinout which uses AI for early detection and intervention of serious health events. At Livongo Health, Afsana served as VP of Health Plan Strategy and Sales, where she established reimbursement pathways and brought the company's digital diabetes solution to millions of people via large health insurance companies and employers. Livongo achieved an IPO in 2019 and was acquired by Teladoc in 2020. Afsana also co-founded Skin IQ, a company that uses AI and machine vision to help people better manage their skin conditions. Afsana holds a bachelor's and master's degrees in electrical engineering and computer science from MIT, where I first met Afsana. We're pleased to have Afsana lead our second session.
Thanks so much, Professor Lin. It's my pleasure to be here, and I also very much enjoyed the session one earlier today. I wanted to just take a few minutes sharing my perspective and experience in having worked at digital health for 15 years in the for-profit sector, trying to really turn digital health companies into financially viable companies, and also trying to get those digital health solutions into the hands of the masses. Primarily by commercializing them with enterprises and institutions such as employers, health insurance companies, and health systems, and trying to find reimbursement pathways. And then those institutions would in turn get the digital health solutions into the hands of patients and consumers. And it's been a very rewarding time doing that for 15 years, but what I can say is there's just such an abundance of amazing innovation already there. And I think we already know this. There's just constant investment, innovation happening, integration, and all of those things happening. But the challenges have always been, I mean, despite all of that investment and innovation, there's still there has been historically such low adoption in comparison, and the barriers that I would feel day to day were institutional barriers, they were systemic policy barriers, reimbursement barriers, as well as just the plain inertia of consumers and us as human beings, you know, latching on to what we're familiar with. So it's been a real uphill battle for digital health in the US in so many different ways. And as Michelle said earlier, despite so much of the loss and tragedy of COVID-19, what it has done is really taken away a lot of those barriers, both at an institutional, systemic, reimbursement level, as well as at the consumer level. And it's really propelled digital health forward. You know, we hear these stats every day, but to me, they never get old. The fact that in the US between April and July, we had 41 million telehealth claims in those 4 months. Whereas, you know, compared to the same time last year, this represents a 4,000% growth in the use of telehealth. It's just amazing. And then during COVID, half of all primary care visits were happening over telehealth. So we really have an unprecedented opportunity here. And in our session today, we have experts, we have researchers, practicing physicians from around the globe, the US, but as also Canada, Singapore, Japan, and the UAE. And they're here to share their experiences with global innovation, as well as digital health, both from before COVID, during COVID, and their perspective on how things may pan out after COVID, which we're all looking forward to. So I'm very pleased now to welcome our keynote speaker, Mr. Steve Davis. Welcome. I'm going to take a minute to introduce Mr. Steve Davis, who's made some amazing contributions to the field. Mr. Steve Davis is a senior strategic advisor and the interim director of the China country office at the Bill and Melinda Gates Foundation. He is also a lecturer at the Stanford Graduate School of Business, a distinguished fellow at the World Economic Forum, and a member of the Council on Foreign Relations. Mr. Davis serves as co-chair of the World Health Organization's Digital Health Technical Advisory Group and is a member of numerous boards and advisory committees, including the Trinity College and Philanthropy University. He is the former president and CEO of PATH, a leading global health innovation organization. And I have to put in here, I don't know if you made the connection, Mr. Davis, but a family member of mine was on the board of PATH, my mother. So I have huge regard for that organization. She's said amazing things about it. And he is also the former director of social innovation at McKinsey & Company, a global consultancy, as well as the former CEO of Corbis, a digital media pioneer. He was also the former attorney at the law firm now known as K&L Gates. Mr. Davis holds degrees from Princeton University, University of Washington, and Columbia Law School, and also studied at Beijing University. He speaks and writes regularly about the intersection of innovation, technology, and social impact, and has extensive experience working with China. He is the author of the book Undercurrents, Channeling Outrage to Spark Practical Activism. He lives with his family in Seattle. So now I'm very pleased to hand it over to Mr. Davis.
Thank you very much. Let me see if I can pop this up. Yeah, and I didn't know that, but the connection with your mother, so that's exciting to know. So greetings, everybody. I hope you can see my screen and you can hear me okay. I come for you from the United States, and where it's now late at night here in Seattle, but it's very much a privilege to be part of this conversation, and I hope that I can provide some insights from my vantage point. So I was thinking to start this with a bit of a story that wasn't but less than a year ago that I was sitting in a Senate hearing room in Washington, D.C., in one of those big sort of over-the-top Senate rooms where we were issuing, as a member of a National Health Security Commission. I was a member for the Council of the Center for Strategic and International Studies, a report on getting America prepared for what could be a pandemic. And I was the author of the piece of that report, which focused a lot on the need for more innovation, particularly around digital tools, digital health, and digital innovation. And I remember meeting with a number of senators and congressmen from both sides of the aisle that day, and we started chatting about this potential outbreak that we were just hearing a little bit about coming out of China, and suggesting that maybe that could change the course of the way we were thinking about some of these digital innovations. And of course, as you've been talking about all day, it did, and did profoundly. And so, I don't need to tell you the scope and depth of the tragedy of COVID-19. We're all living it and breathing it every day. I know I'm working a lot with my various hats, but it has indeed been a moment of deep tragedy, confusion, and a lot of incoherency. But it's also been a moment where we've seen what often happens in crises that impose upheaval and pain. We've seen stories of extraordinary human response, community responses, and certainly brilliant new approaches to problem solving and powerful collaborations. And that's the story I want to talk a little bit about tonight, as COVID-19 actually provided quite a petri dish for real-time studies of both social innovation and digital health opportunities. So I'm going to do that with the perspective. Make sure I get this where I get page down. with many perspectives, and I don't want to leave much time on this slide, but I am coming into this with perspectives both as a practitioner, someone who spent a lot of my time in the private sector, someone who thinks about this from an academic point of view, someone who's in the middle of trying to figure out how to implement it cross-border, with China and otherwise, but also very much from, and probably most specifically for tonight's talk, around my role as the co-chair of the World Health Organization's Digital Health Technical Advisory Group. So I would start with the premise that this has been a digital pandemic. And of course, some people are saying that as it relates to the negative side, which has been there, misinformation, the pandemic, the infodemic that has continued to plague us around, and we'll see more of that as we go to roll out a vaccine in the next 12 to 24 months. But it's also, the first time that we've had a global crisis in the digital age of this proportion, and that I would say the digital environment showed up brilliantly. Obviously we're all doing this through Zoom. We're teaching our kids through Zoom. We're having business meetings and family dinners and weddings and funerals and cocktail parties remotely. We're seeing an enormous acceleration of online education, whether we like it or not, at a scale that really won't go backwards. And of course, we've seen, as was mentioned, enormous amount of utility of new virtual tools and of course profits coming from that in the last year, which have been staggering for the technology companies. And that's also very true in health. And it sounds like I don't need to repeat what's already been discussed in terms of just an amazing amount of innovation that have actually done so many aspects of this disease, from teaching and testing people to monitoring temperatures, to tracing movement, to adding depth to our understanding of where the spread is. And AI is predicting new hotspots, and our ability to get ahead of this and the next pandemic and accelerate drug and vaccine trials has been enormous. So as co-chair of the WHO's TAG, we have seen firsthand the amazing response. And I would say we've been on the receiving end of the fire hose of innovation. And we've actually then been able to help participate in how to shape some of this innovation for the goal of broader global good. In fact, it became so thrilling and sometimes overwhelming because, of course, anybody that seemed to, with an ability to code, seemed to have an idea and a desire to pitch in. And yet the lack of integrated government response plans, the lack of coherency across mechanisms, and the clear lack of clear normative policies, and honestly, just the sheer lack of strong resources for sustainable impact created many obstacles to realizing the impact of these observations. So in the kind of assessment, this was a pandemic in which, we've seen the good and the bad and the ugly, and some lessons learned. So let me talk a little bit about, my assessment of what some of those early lessons are. It's obviously too early to do a full recount because we're still very much in the middle of this pandemic, and I say that particularly sitting here in the United States. But I think we're starting to get a bead on some of the things that some lessons. First of all, let me speak about the extraordinary commitments, innovations, and collaborations. I mean, we have seen the volume and intensity of digital health innovation as it relates to this work, as this pandemic is been, has been described, has been really unprecedented, and that goes from not only the level of innovations, just the sheer number, which frankly has overwhelmed health systems. So one of the things we do need to understand is that many public health systems at the local, national, regional, and even global levels were feeling completely overwhelmed by so many digital tools and digital ideas and willing digital entrepreneurs to come and help them, that they got paralyzed, and it became actually a choke point for many health systems. So so I want to really underscore how extraordinary it was to see the volume and the intensity and the agility of companies to raise their hand and across all sectors, nonprofits, multinationals, entrepreneurs, governments. It did come at somewhat of a price. The other interesting observation that these were innovations that were hitting at all levels of the innovation value system chain. So this was not just, you know, kind of new ideas. There were ideas for how to scale up things. There were ideas for how to accelerate regulatory review and approval. There were ideas for how to reach last mile. The entire journey from the garage to the last mile, we saw innovation and digital health innovation being propelled. We also saw it crossing sectors. And this is notable because in some ways, something that at least in my teaching at Stanford, I talk about is how we still see too many single sector or some solutions being thrown at some of our most important social problems, where either it's a private sector solution full on, or a government solution, or a social sector solution. And actually, in this particular instance, we saw many collaborations across the private, the social, and the public sector, and that was actually quite astounding, actually, to see the ability to people to fortunately in a crisis come together and actually put some of their typical bias and mythology about the other sector aside. We also saw a lot of interesting collaborations, and I was working on several, but one in which, for instance, the World Economic Forum created a top link up model to source the best digital innovations and then find ways to link them with other with either funders or technical partners or users. So we've seen a lot in the sort of the global matchmaking efforts. I'm going to actually not spend too much more time because I want to conscious of time and also the opportunity to answer some questions, because I could list many examples of great innovations. The Common Pass technology that is helping us through a multi-sector collaboration, helping us to figure out how to manage travel in the area in an era of post, particularly once we have a vaccine, and then the retooling and the agility of companies like Damagi and others to retool their CommCare platforms to go from enabling healthcare in the field to using it for helping support tracking and treating and tracing. And then, of course, we can look at some of the large tech collaborations, like the work that Tencent has done on the COVID-19 tools in China, or that Google and Apple did with their now more and more increasingly ubiquitous ability to identify someone who might have been exposed in your own community. So I'm going to move on to mention that I believe that the other sort of meaningful observation of the epidemic and the digital health is the focus on scale. And of course, this is naturally a moment, but we have seen many brilliant technical digital health products never get to scale. And that's been one of the curses of the nascent industry, and particularly as they apply to social sector application in low resource settings or in vulnerable vulnerable communities. And in this instance, one of the criteria for most health systems who are looking at new tools was this able to scale? How fast could we get this into the hands of the people that need it the most? And so I think one of the things that I hope we take away, and this is actually the class I teach, is some of the lessons we learned about scaling digital technologies. But now let me actually highlight sort of the next part of the agenda, which is that where we saw a lot of constraints and where we have some challenges that we need to address, and where I think we should put some energy coming into the next year or two in rethinking how we do things. The foremost challenge is the dearth of mechanisms to link supply and demand in a timely, effective, and financially viable manner. We repeatedly saw innovations fail due to poor fit between product and its target market. We repeatedly saw people putting forward ideas that they didn't know the mechanism to get it into the hands of the public health systems that needed it. We saw a paucity of information about particular tools and capabilities and underlying technologies. Certainly pricing was not always transparent, and the evidence of effectiveness meant that people were often relying on word of mouth, Twitter feeds, and other unreliable ways to actually promote good technical products. And that actually led to a growing digital divide, which I know was spoken about, where the folks that had the ability to identify and find it were the lucky recipients, but many were not so lucky. We also saw the inconsistency in policies and governance. Underlying most of this innovation, these applications, there was a at best a patchwork and at most a vacuum of clarity on interoperability rules, a lack of underlying policy frameworks for data and data governance, a lack of confusion about data sharing protocols. And until that is addressed comprehensively and more intentionally, the gap between our surging technological capabilities and comparatively weak regulatory muscles will continue to impede the impact of opportunities for our innovation. We also saw, as mentioned, a large amount of inequality in access, and which is too bad, because of course digital tools and some of these opportunities gave rise to the opportunity to reach communities in new ways and in affordable ways. But nonetheless, I think our early track record would show that the more affluent communities and more affluent health systems got the advantage of most of the best innovation, and we're still struggling to figure out how to get some of the more important innovations into many populations. And so this is, has plagued us, but this has been really a spotlight's been put on it. And finally, what we saw was a lot of unsustainable economics. So the many exciting ideas were put forth, and incredibly generous offers were made to the community, to the global community, by companies and by governments to support digital innovation during the pandemic. But there was not a very much, and of course, there's been a lack of clarity on what the terms of those engagements were on an ongoing and sustainable manner. And there's simply not a global mechanism in place at this point with the level and the scale of like a Gavi is for vaccines or other kinds of tool mechanisms. We have the Global Fund for broad-based commodities. We do not have that clear mechanism yet. What is a sustainable financial approach for better innovation and better digital capabilities in a pandemic, and actually how is that going to be financed over time? And so that's obviously while there was like over $1 billion the WHO has reported in donations in this area, we still lack the mechanisms to ensure that digital public goods are available and financed for the long term in the same way we funded vaccines for polio or treatment for malaria. So what are some of the core lessons that I take away from this and that we're actually starting to work on now? Let me go down one page. Here we go. I'm not sure why that didn't happen. Whoops. Page up. First of all, I think we've learned that there really is an enormous role for social innovation in the time of a crisis. And I think that's been the theme of this conference. And in fact, a more explicit theme that I think we're taking to heart is the role of digital in global health security has never been more acute as we look at how do we get ahead of another pandemic? How do we do better surveillance? How do we have faster response? But I think we've seen, and I've underscored this repeatedly in a lot of conferences, that this is an area where to sometimes, particularly, and I come out of the private sector technology environment where we think regulation is sort of sometimes the enemy or the thing we want to avoid. We actually are coming to, in this environment, the lack of good regulatory frameworks and the lack of policy has actually impeded some of this innovation from getting to scale. And I think that needs to be thought of very differently as we move forward. We do need new mechanisms for global digital public goods. We've recognized that we're starting to start to think about what that means to have a digital public good, but we're starting to have conversations about what are the various mechanisms to enable the vetting and the selecting and the pricing and the regulatory standards that need to come along with that and fit into country digital health strategies. We also saw a need for technical assistance and incentives to scale. So we saw many instances of where there were actually quite interesting innovations, but and they got to the systems that needed them, but there wasn't any really long-term support. And as I mentioned, some building on some of the multi-sectoral models. So my final comments are then, I think what we need to do is embrace the concept enshrined in the United Nations Digital Roadmap to approach digital innovation as a global public good while protecting the interests, commercial and other interests of the innovators. Second, we need to clarify the rules of the road for more consistency on policies around information privacy, platform interoperability, data governance, and ethics. Third, we need to design means akin to the Global Vaccine Alliance for making qualified digital tools available to those in vulnerable communities so often left behind through a mechanism that provides more funding, screening, advocacy, distribution, and support. Fourth, we need to develop initiatives, technical assistance, and incentives to scale those innovations with the broadest utility rather than focusing at ideas aimed only at a few. And finally, we need to ensure sustainable and substantial financing through multi-sector investment schemes that have clear value propositions and metrics for success. So in the spirit of let no crisis go wasted, COVID-19 represents an enormous opportunity to better coordinate strategies, ensuring that life-saving impacts of digital innovation can flourish at scale. The pandemic has focused the world's collective attention like nothing since World War II. And our response to that earlier crisis was the creation of the United Nations, which provided an important framework for international cooperation. Nearly a century later, we need in this new arena a time focused on digital diplomacy. And the stakes have never been higher. To meet them, social innovators and digital health entrepreneurs must be as innovative on policy as we are with products. Thank you. And I can take questions for a minute, but I don't see any, but maybe I'm missing.
Yes, if folks have questions, please feel free to enter them in the Q&A section or in the chat. Either one would be fine. But thank you very much, Mr. Davis, for the very inspiring talk. And what we will do now is we will introduce our next speaker, which is Professor Kendall Ho. And I will take a minute while Professor Ho, if you want to start sharing your screen, that would be fine. I'll just take a minute to provide Professor Ho's background. Professor Ho is Professor of Emergency Medicine at the University of British Columbia in Canada, where he is a practicing emergency medicine specialist and lead of Digital Emergency Medicine Unit. His research is in the area of digital health, using technology innovations to support patient care in emergency departments and transition to the community. He enjoys research partnerships in British Columbia, Canada, as well as globally. Professor Ho is the lead of the real-time virtual support pillar of the BC Emergency Medicine Network, developing virtual care pathways in partnership with BC Ministry of Health and other organizations. He is a member in provincial, national, and international boards and government committees in digital health. He is the academic director of the UBC Cloud Innovation Center for Community Health and Wellbeing. Professor Ho is an elected fellow to the Canadian Agency of Health Sciences and a fellow of the Royal College of Physicians and Surgeons of Canada. So with that, I'm very pleased to hand the screen over to Professor Kendall Ho.
Great. Thank you very much. Really an honor to be here. It's my pleasure to be able to participate in this International Society Digital Health Conference. Can everybody see the screen and hear me? Just want to do a quick technology check here.
Yes.
Okay, all right. I assume you can hear me. Thank you very much. What I'd like to do is very fortunate to be here, and also Mr. Davis give us a really insightful, great presentation. What I'd like to do is just speak a little bit about in the province of British Columbia, where I live and I practice, how we are leveraging digital technology to support COVID management. And from today's COVID, how do we lead to sustainability? For our international audience, just want to give you a bit of context of my province. It's one of 10 provinces of 3 territories. It's the westernmost province. The geographic area of British Columbia is a size of about 3.5 times the size of United Kingdom. Yet in terms of population, the total number of people that live in this land is about 5.1 million, which is about almost 8% of the United Kingdom population. In fact, if you look at the graph on the bottom right, bottom left dot, Vancouver, 2 million people live there. And so as a publicly funded health system, we want to value equity of care. Yet we do have clinical care gaps in general that we need to overcome. For example, the fact that we live in Vancouver compared to live in regional or rural locations or villages where there are 100 people or less. How do we deliver equitable services over time? Secondly, if you have an emergency, such as a car accident in Vancouver, as opposed to a car accident on a highway in a very remote location, again, care, the challenge of equity of care is there. The third is that all the population are well served by primary care doctors, nurses throughout the province. But once we start accessing specialty care, for example, mental health, trauma, internal medicine, or strokes, that's when we start having challenges. How do we bring specialty care to match with primary care in the different locations to create optimal care for our patients? And of course, in a province like this size, cost effectiveness of delivering care is again very important. So all these are factors and context that leads to some of the inequity that we face. And one of the areas, of course, that we've been looking at is technology. And so today I'll be focusing a little bit more on the virtual care or telehealth, the use of technology to deliver health services. Here was an article in 2017 describing the 3 paths of how technology deliver care. Number 1, clinician to clinician. So using technologies like what we use today right here, or using text messaging, that peers can talk to each other to deliver team-based care in a virtual way. Secondly, is clinicians and patients. So again, using mediums like this, we can see patients, we can deliver care, we can talk to our patients for follow-up or any screening type of activities. The third is patient to technology. Our mobile phones, our watches that actually monitor our physiologic states. And with that monitoring, the patients can optimize self-management, but also can share data with the health professionals. So these are the three ways that technology overall can deliver type of healthcare. And this article in 2017 was talking about the fact that at that time, it was really a boutique type of care services. How do we, as Mr. Davis asked, scale this to lead to a global service that delivers care equitably? And of course, COVID changes everything. In many ways, in a very negative way, but again, in digital health, it actually accelerated, for example, virtual care. Now, this was a study, Afsana earlier on has already talked about the fact that in digital health, there's a significant increase, 4,000% increase in telehealth billings in the United States. This article in US, again, was reflecting on the fact that before COVID, the use of telehealth was about 1 in 10 patients experiencing it. But after COVID, or during COVID, that number rose in June to 3 out of 4 individuals having experienced it. And in the US, a 50 to 175 times use of care of telehealth. In Canada, we also surveyed across Canada and found that by the time in end of May, that 1 in 2 Canadians have experienced at least one or more episode of virtual health. And for those who did, 90% of them felt that it was a very positive experience. So in British Columbia, me in the Department of Emergency Medicine and BC Emergency Medicine Network, working with a group of organizations, as you see on this slide on the right column, that we work with Ministry of Health, the Doctors Association called Doctors of BC, health authorities together with academic institutions, that we set up 8 lines of virtual care since March till now. The diagram of the left illustrate that system of care. So it's not a one line of service, but how do we as lines of services work together? That diagram really is broken down to 2 parts. Patients and health professionals in the top, serving our indigenous communities, especially communities. We have 104 First Nations communities distributed throughout British Columbia. And how do we deliver services to them? And also a provincial service, which I'll talk about, is 811, a phone number that any citizens in our province can reach. And then the bottom half are the different types of peer-to-peer support available as a health system to support patient care. Let me talk a little bit about 811. And in fact, this is a number that patients can call. As opposed to 911, they call for an ambulance. 811 is to call for questions or information for patients. And it's not surprising that as COVID become more and more growing in the February and March period of time, that there's a significant number of calls that go into this call center who are staffed by nurses. And so with the calls becoming more complex, with the disease evolving very rapidly with lots of questions, do I need to get tested? Do I need to go to emergency departments? How can I make sure I don't get contracting this COVID disease? That there is not only a physical need of knowledge, but also emotional need for calming. And so a group of us as physicians were invited to join 811 nurses, 150 of nurses. We had a workforce of 45 virtual physicians that we can increase the capacity to take calls all through the province, but we can also support the triaging of patients so that if they need to go to emergency, we'll direct them, but can we save capacity with the phone calls? And we want to address the mental wellness of our patients and also to make sure that if they don't need emergency care, that they'll be streamed back to their family doctors for care. And so since April 6th, we started the service, and we're on average seeing about 70 to 80 patients a day over a 12-hour span. And since April 6th to November, we've seen 15,000 patients as we go through the system. And we found that, in fact, interestingly, 80% of the time, a phone call would be sufficient. We don't necessarily need to go to videos like what we see today. But for 20%, video is indispensable. is this a COVID-related rash? If I have this cut, do I need to go to the emergency department and wait for hours to get sutured? But at the same time, get risk of getting COVID. My kid is very sick, but for health professionals, we can actually look at the child and to see how he or she interacts as a way of diagnosis severity. And so we also found that, in fact, 7 out of 10 patients who call the service, and with us physicians participating, that we can decrease them avoiding emergency departments. So 7 out of 10, we can avoid emergency department visit. For the patients, they are a lot happier that they don't need to wait in the waiting room. They got the information that they need. But for the health system, is to preserve that emergency department capacity so that we are not overwhelmed with cases. But in 15% of the time, we actually accelerate patients going to emergency. The patient perceiving indigestion, they're actually having a heart attack. And so we can stream them much faster, go to emergency department in those cases. And we found that 98% of the patients feel very satisfied with this type of service. And so that's the health professionals to patients. The peer-to-peer, again, recall the geographic distribution of our province. How can we as emergency physicians support our rural colleagues to deliver care? And so you can see that we use generic technology like a digital pad, and we download generic software like what we're using today so that we can do this type of services. And our consultants come in by mobile phone or using their digital pads so that we can connect and see our patients. So we have emergency services as our premier line, first line, and then we added intensive care, pediatrics, maternal and child care, mental health, and then for the last 3 months, we started to add dermatology, rheumatology, and hematology so that we can start accelerating colleagues working together, distributing throughout the province, as you have seen in the different sites that we have reached. This is just a snapshot of one of our lines where you can see that from April to September, we have a rapid growth of the use of this line, the light blue. But then we do test calls in the deep blue. And just like defibrillators, we don't want to use it only when patients have their heart stop. We want to practice using the defibrillator. So in the same way, we want to practice so when time comes to use the video technology, we can do that. And in fact, many of the rural communities are able to benefit from this type of services together. Finally, I'm just going to bring up a couple more things and I'll wrap up. This is home monitoring. In fact, 4 years prior to COVID, we were able to look at heart failure patients using technology to support them at home. For patients with heart failure admitted to hospital and at discharge, 1 in 4 to 1 in 5 of them need to be readmitted to hospitals, and 3 out of 10 need to be readmitted within 3 months. By sending them home with blood pressure cuffs, weight scale, digital pad to ask how they feel, a bit of standardized care so that they can use self-support, and a nurse monitoring them, that we found that we were able to, in 3 regional hospitals with a feasibility study, that we're able to decrease hospital readmission by 59%, decrease ED visits by 44%, and cost decrease, and patient feel better. So as a researcher, I love that. But as an emergency physician, I love this. The patient said, this is the best I've felt in 2 years. This is the longest I've stayed out of hospital. And people who've not seen me for a while say, what a difference. And so in fact, back in 2019, we went into 21 communities, this scaling up of this virtual care. And because of COVID, we rapidly transfer this system for COVID monitoring for that type of care. And so finally, there are a lot of digital infrastructures that I haven't talked about. For example, contact tracing, using apps and chatbots, home monitoring that we just talked about, longitudinal patient records with electronic medical records that we can track patients throughout the province, and public health and chronic disease data analytics to analyze the pattern of care that we use in British Columbia. And so in conclusion, technology can be well used, as Mr. Davis indicated, but how do we scale it in the province so that at the end of the day, it's not only about a safety net for our patients anywhere they live, that they have the type of services, but how do we funnel the different patients so that a publicly funded service can support them as primary care, as specialty care, and especially time of vulnerability of emergency care. And finally, how do we work as a fire station so that when there's COVID, we want to put out a fire, but between the COVIDs that we can practice, we can learn to engage, we can support our patients so that for today, it may be accidental, maybe lucky that we get through the first wave of COVID. But as we move to this next wave of COVID in the future, that practice make perfect. So it's no longer that we rely on luck, but rely on practice in collaboration and relationship to support our patients. And so we've been developing a VGH Emergency Department Living Lab to do these type of innovations that we have. And we look at digital emergency medicine in the sense that it's a bridge between home and hospitals. How can we use virtual triage, real-time virtual support, home monitoring, and data so we can support our patients? So at the end of the day, it's not just about high tech, but delivering a high-touch service. Thank you very much for your attention on this.
Great, thank you, Professor Ho. You know, I think we've all at some point been to the emergency room, so hearing this talk about the emergency room may have gotten us all a little worked up, but we have a couple of questions actually. One question came in, which is that, this is the question of the day. I think we'll hear this question quite a bit. Do you think people will still use this kind of telesupport after COVID-19?
Unequivocally, yes. And I also hope that the lessons that we learned today, just as what Mr. Davis has captured, that it will help us to go from today to tomorrow and engaging our patients, our health professionals, our policymakers to evolve our system to tomorrow's care will be very important. I think we'll use it definitely, but it will look very differently tomorrow compared to what we have today.
Thank you for that. And that's a topic we'll revisit again during the panel discussion. So I think we've captured the questions for now. Again, I'd encourage attendees, if you could put your questions into the QA box, that would be very helpful because that way it doesn't get lost in some of the back and forth in the chat. Great. So next, I would like to introduce our next speaker, Professor Josip Carr. Welcome, and I will do a quick introduction for Professor Carr. He is the founding director of the Center for Population Health Sciences and the chair of Health Services and Outcomes Research Program at Lee Kong Chan School of Medicine in Nanyang Technology University. He is also the director of the Global eHealth Unit at Imperial College in London and a practicing physician. He has worked with the World Health Organization, OECD, World Bank, and Global Fund, as well as the Singapore Ministry of Health. He is a board member of the BMC Medicine and Journal of Global Health, and is also an editor of the Cochrane Collaboration. Professor Carr has a track record of blending academic, policy, management, and clinical work. He served in a range of roles, including as Director of Public Health and Primary Care and Lead Director for Integrated Care at Imperial College Healthcare, NHS Trust, Director of National Institute of Health Record, the NIHR, Primary Care Research Network, and co-director of NIHR Comprehensive Local Research Network for London. He was also the medical director and chair of a professional executive committee of a healthcare commissioning organization, as well as primary care and research advisor to the editor of the BMJ, also a director of the Imperial GP Specialty Training, a member of International Advisory Board for the City of Rotterdam. So we welcome Professor Carr to tell us about taking digital therapeutics mainstream and where we are today.
So thanks again for the invitation to speak. It's exciting to meet colleagues now that we can't travel. In some of the bigger countries, you may feel that less, but when you're in a smaller country, you really feel inability to travel for nearly a year now is quite something, and now to be able to meet you all is just amazing and exciting. If this was a live session, I would do at least part of it interactive. I can't see your faces, but I would be looking to ask you some questions and engage in a bit of dialogue, perhaps crack a joke before I started actually this talk. Now, I just need to hope that you're listening to me and not checking your email or sending WhatsApp messages. So, one of the questions I would ask you is how many approximately diseases are there in the world? And I would give you a range, but we can't do that right now, so I'll just give you the answer. It's estimated that there are approximately 10,000 different diseases. Obviously, it depends how you count, and some are really rare, and some are genetic conditions which you may have almost like a single patient, but it's a helpful number to keep in your mind. Yeah. And then the follow-up question really, how many treatments do we have? And again, depends how you count and how you look at combinations. But broadly speaking, it's about 500 different medications. So as you see, we have treatment for about 1 in 20 different conditions. And so my first challenge to you and thought, what is the role for digital therapeutics in helping to change the needle in this area? I'll give you a second piece of information which many of you will know, but some of you may find this as new or as helpful in this context when we think about digital therapeutics. To bring a new medication to the market or to patient care, should I say, rather than market, it's estimated that on average, it takes about $1 billion, so $1,000 million. That's the cost from, if you start from phase 1 trial all the way to this medication being successfully introduced into patient care. Now, I'd like to pause here for a moment and give you another piece of information and then come back to this 1 billion figure. And that is that when we look at the effect sizes of many of the medications today which are on the market, so let's say a patient has diabetes and they're given a medication and this medication doesn't quite achieve the desired outcome. So the option that the doctor has, and myself as a physician, would be that I either change the medication or I may add an additional add-on medication. And that might be for a number of other conditions such as hypertension and so on. And very commonly, the effect of the second medication we add is really quite small. And patients may not appreciate that. And in fact, many will not appreciate, and I try to share this with patients, that just strong emphasis on exercise or diet is going to achieve a greater effect than taking a second or third or even more medications for the same condition. Now, when you think about that and what, again, digital therapeutics could do, let me come back to that figure of 1 billion. It is recognized theoretically and also in practical terms that the effect sizes we can expect from digital therapeutics in many instances could be at least comparable to many of the drugs that we use as a second or even as a first medication, and certainly comparable to many other therapeutic interventions. And those have a development cost 1 billion. I'm not aware of any digital therapeutics which anywhere remotely approaches this number. Now, I'm not arguing that they should. I'm just highlighting to you how to bring something globally to patient care to improve outcomes. We're really in a different game, and that perhaps some of our framing, how we look at these challenges, needs to change. And I'm giving this as an introduction to where we are today. Here is a brief definition of what digital therapeutics means. It's a new concept, and in fact, so much so new that different people will understand it differently, will define it differently. But broadly speaking, when we talk about digital therapeutics, it's about the fact that the software, or as we call software now, an app, has on patient intensive prevention, management, or treatment of a medical disorder or disease. And it could be used independently or commonly, like think about the second medication being added in concert with other medications, devices, or other therapies to optimize patient care and health outcomes. And that's important to think. It's not just the health outcomes. Improving the patient care equally has a beneficial effect. If no other, it has in terms of patient experience, in terms of the cost saving for health system, and is as important as improving health outcomes. And we sometimes think very narrowly in that sense, and this is very helpful to think more broadly where the impact of digital therapeutics can be. So no need for you to go and look at each of those. These are some of the examples of the current digital therapeutics which are on the market. My key point on this slide actually is that I've given you the vast number of conditions and diseases where we could consider using digital therapeutics, the available therapies on the market are really very small. You can almost count them on fingers. And importantly, when we look at guidelines, how many have been created robust evidence that they would become part of the medical guidelines for different conditions, treatment, and so on. There are really hardly any. There are a few who are FDA approved, but moving forward, nothing much more. What could be the benefits of digital therapeutics? And I know that if you came to this conference, you don't need to be convinced about this. I'm not speaking to the skeptics. This is more likely than not a group of enthusiasts. There are multiple, as highlighted, but important in all of this, they are reaching into where the traditional therapeutics may not be able to work or may not be affordable, or is creating new opportunities and new avenues for improving process and outcomes. And in that sense, you see that then the way that digital therapeutics is defined, it has a different categories. And looking further at how digital therapeutics can be brought to mainstream, and something that I believe that each country should take very seriously in terms of R&D, in terms of investment and mainstreaming. There are a number of core principles that need to be satisfied. Some of them are very common sense, and they are like ensuring if, remember, this is a piece of software, that this works safely, reliably, that it's secure, protects confidentiality, etc., etc. But there are others which are less intuitive for those who are in the medical field and are thinking about this as in being introduced. And we have two perspectives. There are engineers who approach this and they approach it with the disruptive mind and saying, we're gonna transform healthcare, forgetting that medicine is a heavily regulated industry. And introducing disruption versus accepting the current rules of the game, i.e. the guidelines, the robust evidence from the academic publications and so on, may be a faster and easier way, although it seems quite onerous, to come to the mainstreaming of a solution. On the other hand, there are those who will be questioning primarily, how does this medication or digital therapeutics, achieve its desired engagement from the patient, use, and so on. And to those, one simple response would be that when we look at the traditional medication, on average, again, that would be a question if this was a live lecture that I would ask you, what is the average medication adherence or compliance with a prescribed medication? It depends from condition to condition, but it ranges around 40 to 50%. So only about half of the medication prescribed is taken as intended in terms of frequency, in terms of amount, etc. And when you bring that piece of information into context of thinking about digital therapeutics, and you say, oh, okay, that might be more realistic goal to achieve, even if we can help half of them, or maybe 20 or 30% or 40%, that will still be a big win. And but then there are some specific questions which the digital therapeutics is prone to challenges of rapid software development, of if this is mobile phone-based, operating systems which change on an annual basis, change form factors, and so on. And essentially questions of when and how should we be retesting those as those changes? What should be the triggers at which proven digital therapeutics should be reevaluated? And we don't have very good answers to those questions. I mentioned earlier about approval and need by regulatory bodies, that's probably a lot safer and faster way of mainstreaming digital therapeutics rather than trying to go a way of disruption, which we have seen that even the biggest players like Microsoft, Google, and others, when they tried introducing electronic health records, perhaps more than 10 years ago, had mixed results at best, and so needed to rethink this. What to say about clinical trials for digital therapeutics? If I want you to take just one message away, is that we need the same highest standard of, you can think about phase 1 trial, phase 2 trials, and we are particularly now all familiarized with this terminology with testing of vaccines, where we which take the same principles as do medications of having phase 1, phase 2, phase 3 trials, and then continuous, even post-marketing evaluation of the therapy. The same rigor needs to apply to digital therapeutics. And unfortunately, we see that that is very often not happening. Apps, health apps, medical apps are trying to be introduced and launched with not as much rigorous approach as we would see with traditional medications. So there are other criteria in that sense, and I won't go through all of them. I'm just illustrating some of them, but having a very strong, for example, health technology assessment and health economics analysis is as critical, with some realistic modeling about the adherence, such as I mentioned before, maybe 20, 30, 40%, and not necessarily expecting that every patient who is prescribed digital therapeutics would be using it. So in summary, we see that the challenges are still many, and we don't have regulators who are familiar with that. We don't have many precedences of successful therapies, digital therapeutics, which are mainstream. None, to my knowledge, is used globally. None is even used widely internationally, not for single condition. Unless we really narrow it to closed loop systems of software, perhaps for insulin, but that's slightly different, perhaps, category. But if we look at something which has a wider application, we are really in a very early phase where there is huge potential, but not quite yet implementation ready digital therapeutics. So I talked already about this, so I'll skip this, just re-emphasize about the need to think, how do we get with this piece of software into guidelines? What are the steps that we need to go through to get into medical guidelines? Because that's an assurance for every physician who is prescribing, yes, I don't need to think twice if this is appropriate indication, appropriate patient, and all the other usual considerations. I can treat this in the same way and approach in terms of prescribing and evaluation as the traditional medication. So thank you for listening to me, and I look forward to hopefully an engaging discussion.
Excellent. Thank you, Professor Carr. We will have, please feel free to submit questions. Professor Carr will be on the panel, so we will have an opportunity to hear from him again. Our next speaker is Professor Tomohiko Moriyama, and I will take a minute to introduce him. Welcome. Professor Moriyama is a physician as well as Associate Professor of the International Medical Department and Vice Director of the Telemedicine Department, Center of Asia at Kyushu University Hospital in Japan. He has worked as a gastroenterologist and also an endoscopist for 20 years. He has taught gastroenterology and endoscopy to more than 100 residents and many foreign trainees. Since 2016, he has been involved in a telemedicine project, which was adopted in many Asia-Pac regions and has been expanding globally. We'd love to hear about that since we've been talking about things going mainstream. Also, Professor Moriyama is now the Secretariat of the Medical Working Group of the Asia-Pacific Advanced Network. And Professor Moriyama will be speaking of the role of telemedicine in COVID-19. Thank you.
Thank you for your kind introduction. This is Dr. Tomohiko Moriyama from Kyushu University Hospital. So just wait a while. I will share my movie. Okay, I'd like to start the session. So I'm Dr. Tomohiko Moriyama from Kyushu University Hospital, Japan. I'm an endoscopist and also Vice Director of International Medical Department at Kyushu University Hospital. So I think the digital health have two targets, students and medical workers. Today's my topic is telemedicine for medical workers. Okay, I think that telemedicine can be divided in two parts. One is doctor to patient, including remote patient care, remote surgery, or something like that. And another is doctor to doctor education, such as remote education for doctors or medical students, remote diagnosis, remote consultation, and something like that. Today, our activity is mainly focused on remote medical education to doctors. So today, I'd like to show our activity. This is a heat map of age-adjusted gastric cancer incidence. As you can see, Southeast Eastern Asia, including Japan, China, and Russia, Central Asian countries, Eastern Europe, and Latin countries are high-risk area for gastric cancer. But the situation in Japan is a bit different from other countries and other areas. Okay, the incidence of gastric cancer is quite high in Japan, but its mortality is less than its incidence, less than half of its incidence. But in other countries and areas, the gastric cancer incidence and the mortality is almost same. It means once the patient is diagnosed as having gastric cancer, most of them died of gastric cancer. What's the difference? Actually, most of gastric cancer is diagnosed at early phase in Japan. So we have so many knowledge and experience to find early gastric cancer by endoscopy. Okay, all these photos include the early gastric cancer. Can you find the abnormality in these photos? Here it is. Okay, without detecting such kinds of subtle changes, we can't save the life of the patient with gastric cancer. So we go abroad and to have an on-site training and a live demo in each country. And also we have invited many foreign doctors to Japan to share our knowledge and experience with foreign doctors. Such kind of human exchanges is very, very useful. But do you think these activities are sustainable? Of course, there is a time limitation. And also we have to pay travel expenses to go abroad and to invite the foreign doctors to Japan. And furthermore, the very limited doctors have a chance to come to Japan and go abroad. So even though this human exchanges is very important and effective, but it is not sustainable. That's why we started this telemedicine activity around 2000 using internet. In this photo, you can see many Asian institutes. By connecting these institutes, we had a fruitful discussion on endoscopic findings. And through such kind of discussion, we can share the knowledge and experience. Okay, by telemedicine, we can make medical education sustainable. And this is a traditional and conventional style of live demonstration of endoscopy. The participants get together in the main venue, and the foreign faculty, who is an endoscopy expert, go to the main venue and the hospital located near the venue and show their endoscopic procedure in that hospital. But they should do their procedure in totally different atmosphere. Of course, endoscopic room is different from their own hospital, and some equipment and the team members are also different. And sometimes indication for endoscopic procedure is different, and they foreign doctors cannot take care of patient after the procedure because they have to go back to the country after the Congress is closed. And of course, some doctors feel some language barrier, and sometimes we feel jet lag even during the procedure. And for the organizers, they should prepare the lots of patient for the live demo. So this is a new style of live demo from their own hospital. The participants get together in the main venue and watch the expert procedure there. And foreign experts do their endoscopic procedure from their own hospital. For organizers, there's no need to prepare the lots of patients. And for guest faculties, there's no need. They can do their procedure in same situation. So it's really convenient for organizers and also for guest faculties. Our activity is mainly focused on gastric cancer. That's why the half of the program is endoscopy and surgery. But we have a variety of programs like this: pediatrics, fetus transplantation, oncology, neurology, or something like that. And also we expand our this kind of communication with nurses and so on. So far, we have held 1,240 events with 948 institutions in 72 countries. Even under COVID-19 pandemic, such kind of a telemedicine can be done. This is a number of our telemedicine in the early phase of COVID-19 pandemic. In 2019, we from April to July, we held 59 events. In the same period of this year, when the emergency declaration was launched in Japan, we held 50 events. A little bit decreased, but almost the same in number. And at that time, we remember the past experience on bird flu. In 2007, Asian countries and Oceanian countries are suffered for bird flu. At that time, there is we have only limited information on this disease, but in Indonesia, they have a lot of experience. So we invited Indonesian doctors who have a lot of experience on bird flu and having some discussion connecting Asian and Oceanian institutes. So based on this experience, we held international teleconference on COVID-19 for 3 times. The first one was held in March. At that time, we connected Taiwan, Japan, the Philippines, and Singapore. And the inviting expert on infection, we have a fruitful discussion and share the experience on these new diseases. At that time, the information on this disease is very limited, even in the world. So more than 3,800 participants watched our discussion. And this pandemic affected our telemedicine activity a little bit. Previously, most of the participants joined from their own institute with their young colleagues, fellow and residents. But this photo was taken in this April. At that time, many doctors should be quarantined at their home, and so that's why many doctors joined from their own home like this.
Professor Saito, who is head of the endoscopy department with the Tokyo-based National Cancer Center.
Endoscopic procedure.
Good morning, good afternoon. And everyone.
Chair.
Okay. The lesion size is about 2 centimeters or less, but located in the sigmoid column. There are 2A plus 2CD.
Professor Saito, do you see already fibrosis on the lesion or not yet?
Joined and
we already encountered fibrosis.
Home.
Yes.
Okay, and now many big, as you know, many big congresses are moving to online. This is an Asian Pacific Advanced Network meeting was held totally held online last August. And many big congress like Digestive Disease Week in US and Japanese Medical Congress are held totally online. And we have supported many Japanese congresses in this pandemic situation. Okay, I will show one of them about the Congress of Japan Association of Medical Information. This year, this Congress was totally held online, but comparing to the last year, the participants was double. And most of the participants satisfied its image quality, session accessibility, and concentration to presentation, except for communication among participants. But now, younger generation love online congress. They prefer to join the online congress because they can join very easily and they can get new knowledges from his desk. So it's really useful and very important in the era of COVID-19. Okay, this is a summary of my presentation. Sustainable medical education can be achieved by telemedicine. Telemedicine is becoming more popular and casual in COVID-19 era. Telemedicine plays an important role to reduce health inequality within and among countries. Thank you for your attention. If you are interested in, please join us.
Thank you, Professor Moriyama. We have some questions, but given we're a few minutes behind schedule, we will save those questions for the panel discussion. And our next speaker is Professor Homero Rivas, who is a professor of surgery and associate dean of innovation and future at Mohammed bin Rashid University of Medicine and Health Sciences in Dubai, UAE. Formerly, he was associate professor and the director of innovative surgery at Stanford University. He was also the co-director of the Stanford Fellowship in Minimally Invasive Digestive and Bariatric Surgery, and has 18 years of experience as a digestive and bariatric surgeon. Professor Rivas has pioneered numerous innovative techniques of minimal access surgery. He is diplomat of the American Board of Surgery, a fellow of the American College of Surgeons, a fellow and co-chair of the International Committee for the American Society of Metabolic and Bariatric Surgery. He has been inducted as honorary fellow in multiple international surgical societies and currently serves as the VP of the California chapter of ASMBS. Dr. Rivas has been involved in digital health and telemedicine for many years, including research projects using wearables before and after bariatric surgery to improve weight loss and adherence to treatment. He is a strong proponent of novel technologies in healthcare, such as 3D printing, drones, AI, and more. Dr. Rivas is co-editor of the book Digital Health, Scaling Healthcare to the World. He holds an MBA from the Cox School of Business at Southern Methodist University in Dallas, Texas, USA. So I will hand it over to you, Professor Rivas.
Thank you, Ms. Afsana. Thank you for the kind introduction. And I would like to say first, it is a true honor and a pleasure to be among very prestigious presenters today. This is a topic that I'm passionate about, and I'll try to give a pragmatic approach to what I see that it's important with digital health in the present moment. I would like to echo all of the previous professors in the sense that there's great relevance, importance, and a tipping point that we have throughout the world when it comes to digital health. I have no disclosures, and I'll try to give just an introduction that I bring to all my students and to sessions such as this one. But medicine has been practiced for thousands of years across the world. And it's interesting because very little has changed over the years. This is a mural from Diego Rivera in Mexico City, where it talks about the history of medicine. And basically for many years, up until now, the business model hasn't changed much in the sense that we do it in one-on-one basis. So we need to rely on a number of physicians to actually take care of problems. As it was reviewed on my presentation, on my introduction, being a surgeon, I am biased for that, but it's the same as with medicine. We've had surgery in one way or another for thousands of years, from very primitive uses of instruments to do a trepanation of the skull, to actually be able to do scarless operations where you actually go through an orifice, much like Prof. Moriyama, being able to do very sophisticated operations through the mouth. But as I said, very little has changed with that business model. And we have a number of different technologies, very innovative. capsule endoscopy, robotic surgery, to do actually telepresence surgery, being able to do things virtually through the mouth or through rectum or other orifices, being able to do major vascular operations that we had to do before, including change of some aortic valves, etc., through just punctures in the skin. But we are faced with the same business model, and in that sense, it's truly non-scalable. It's not uncommon for me to come home and complain about having a very busy day, being in the operating room all day, and at the end of the day, I'm able to actually help only a few individuals, maybe a few families, because I am an academician and I teach. All the people that I teach, they can certainly help some of the people, so that becomes a bit more scalable, but that's almost a very romantic way how to say that we can truly scale. Now we know, and much like Prof. Josip mentioned it, we are among a group of people who are passionate about digital health. The challenge is to tell that to the world and to tell that to all other physicians and other students in medicine, so they can actually see that digital health is the true solution for this. And what do I mean with this? Well, we still have a broken healthcare system in many ways. Having practiced in the US for over 20 years with my education, we can see that even though we had a fantastic healthcare system in many ways, there's still a lot of inefficiencies, and it is something that is non-sustainable. And at some point that's going to collapse if we don't do something about it. Why? Because nearly 20% of the GDP is utilized just in healthcare, with no better outcomes than any other place where actually the healthcare expenditure could be much less. Now this, hopefully, locally it doesn't replicate everywhere around the world. Now in the Gulf, it doesn't replicate. But going to the pandemic, we have some modern age pandemics now that we have lots of digital technology that has led in many ways to other ones that are very much dear to my heart, and that's what I do. And now we have this true pandemic with COVID-19 that has in many ways been an opportunity for people who really believe in digital health to actually leverage in a challenge like this, and to get something positive, much like Prof. Ho mentioned throughout his lecture. So we still have a challenge, with this pandemic. Certainly, lots of efforts have been implemented around the world. Lots of people have suffered. Lots of lives have been lost, and now we're hoping that sooner than later we can have a vaccination that can actually be given to everyone around the world. So hopefully, many of us will not ever develop this problem, but we don't know. So it's like we need to think about new ways how to be prepared for such things, okay? We need to be very innovative. But teaching lots of students, teaching lots of physicians, young physicians, we sometimes identify that some people don't even know the basics of innovation, like much less what would be innovation in healthcare. I just tell people, well, it's just you need to make something easier, simpler, much more effective, faster, all those things. And in healthcare, well, just to take care of some healthcare deficiencies. Nowadays, we're way better prepared than we were 20 years ago, 100 years ago, 1,000 years ago, because we have lots and lots and lots of promising technologies. The challenge is that many of them, if any, as most of the professors have implemented, have talked about, they're not being implemented to the full level that they could be. And we always have barriers of innovation. I was very happy to hear Mr. Steve, talk about some of the barriers that he could see. And one could analyze them all in detail. There's going to be technological, they're going to be economical, they're going to be related to oversight and regulation. But with no question, at least in my experience, the biggest challenge that we have had up until COVID has been the mindset that we have like real deep in our minds as healthcare providers, the mindset that changing the way we practice medicine shouldn't really happen. And so we need to find a way how we can adopt new mindsets of innovation so we can actually bring all those promising technologies that I mentioned just before to actual practice. Now, and that's a huge challenge. That really sounds simple, but it can be a big challenge. And a lot of that is because, the way we've been teaching medicine, it hasn't changed much in the last, 50 years. There's actually no true, in most medical curriculums around the world, this is not something that it's implemented, that is being taught. Sometimes it's even set aside because it's not one of the basic things that we should teach, such as anatomy, physiology, whatever that may be. And something as simple as this, just the basic characteristics of an innovation, lots of people don't get that. And the way I see it, it's because we truly have a fine line, something that should be a fine line, but sometimes it's an abysmal line in between what we have a successful innovator versus a successful physician. And I'm glad to see there's a lot of clinicians in the group of presenters. And here we have a very successful innovator recognized by many around the world. And the profile that they would have in many ways is they truly embrace risk. The more times you fail, probably the better entrepreneur you're going to be, the better innovator you can be, because you've gone through all those pains, you go through all those aches, you actually persevere, you find opportunities and you go for them, okay? That is something that is very unique for those innovators. Now, we have many around the world, and these are just, common public faces that we have, but we see them in our own hospitals, we see them in our own clinics, we see them, among different industries. It's just that, they may not be well known by everyone. But now let's talk about physicians. The way we see a successful physician, and this is the way we're taught, and there's nothing wrong with it, but I think we just need to find a better way to do things, because we're taught never to fail. We are very, very risk averse. And what I mean with this, if my mother needs an operation, I need to take her to see a surgeon. I'm not gonna go to a surgeon that has a 50% mortality rate or something prohibitive like that. Like, for example, that innovator that always likes to fail. We always take the less risk path, the path with the less risk. So we really change very little. We don't tend to innovate as much as we believe we do or we want to do. And even in places like, being at Stanford for nearly 10 years, to bring something truly innovative into clinical practice, it can be extremely challenging. And oftentimes you're going to be asked questions, why is that you want to do that differently? Why this or why that? And in many ways, we're also very secretive about research. Why? Because we don't really want someone else to take what we've done. So very, very few things up until now are being done with open source for that matter. So, in essence, we're narrowly trained. We have very difficult time with ambiguity, and we are not risk takers. So how can we innovate? And this is something interesting because I see it, pre-COVID and after COVID in academia. The professors at the university, everything against something new. If it's virtual reality with teaching anatomy, no, it cannot be done. It should not be done because we need to use cadavers and a number of different things. And what has happened? Well, we get a challenge, a big challenge like COVID, And then the next thing that happens is like, boom, like virtually, they're into everything. Yes, we should do this thing through Zoom, and let's just meet virtually, and let's have a webinar, and let's do those things. And that's a great opportunity. At the same time, it's something that we really need, hopefully we can leverage on when it comes to medicine. So we really need to think outside the box. We need to find ways how we can transmit and truly leverage so this doesn't fade away and goes away. And so at our university, here, Mohammed bin Rashid University in Dubai, this is a young university. We decided since we start, we're going to teach innovation in healthcare to our students, and we teach them all these things that have, include entrepreneurship, include design thinking, storytelling, social media in healthcare, a number of different things, because there's people say things for a reason. It's very challenging to teach an old dog new tricks. And so these young students, they're very open-minded, they're hungry for new knowledge. And once you actually teach them differently, they're gonna act differently. And this is basically what we do with them. We have a number of different classes in their first year. Soon after they finish their high school, they have a true open approach to digital health. And I know for a fact this will be not only a geographical change, but it's going to be a generational change. We have a design lab where we actually, much like many other top educational institutions around the world, we identify healthcare problems, challenges that we have every day, things that we complain about all the time, and we try to fix them. And we don't do that just clinicians. We actually have groups of like multidisciplinary people that involve engineers, computer scientists, people in economy, in business, psychologists, etc., to come up with solutions for that. And we reach out to other institutions here in the region, in this case, Dubai Institute of Design and Innovation, American University of Sharjah Computer School, etc. Because we need to come up with solutions. I think one of the biggest questions that we have had throughout the day and that we're going to keep talking about later this morning would be how much of this is going to persist after COVID. And I do hope that the regulation, the mindset that physicians, patients, all the stakeholders will actually be touched enough to truly adopt this new technologies. I think we really need to do a lot of cross-fertilization among fields. I would invite that the next time we have something like this, we would have even more people from different backgrounds. And yes, while we keep patient-centric strategies, we really need to educate our young generations. This is going to change. It's going to be very different. 5 years, 10 years from now, that's a fact. And some places, perhaps non so regulated places, they're going to lead the way before things happen in more establishment healthcare ecosystems. Having said that, I would like to thank all of you, and I would welcome any questions once we're in our panel. Thank you.
Excellent. Thank you very much for that, Professor Rivas. I think you yourself raised a number of great questions and topics that we can discuss in the panel. So I would now invite our speakers back so we can address some of the questions together. And we'll look at some questions that were submitted from the audience as well. As you can imagine, one of the most popular questions was, post-pandemic, as we emerge from the pandemic, how do we hold on to this elevated level of adoption and use of digital health? I think we've all here expressed that we all want that. You all, everybody in the panel is, I think, a practicing physician, but you're also leaders in your healthcare organizations, oftentimes even at a government level. So my very direct question to you is, what do you think you can do in your roles as practicing physicians, leader of an institution, sometimes leader of in a governing body, to help sustain that level of digital health use as we move forward post-pandemic? Whoever would like to answer.
I'm happy to start. I think there are three things that can help us to really start building on what we have and move digital health forward. Number one is, I think for health professionals, we need to take advantage of this time, and many of the speakers today really speak to it, is to generate this type of evidence for us to sustain and demonstrate that this is a very useful tool, that, for example, digital therapies that will actually make a difference, telemedicine in barometric surgery or gastroenterology, that we actually demonstrate evidence. I think that's going to be important. Secondly, I think for governments, it's not only about evidence, it's about cost effectiveness, value for money. So at the same time, while we demonstrate that, we need to actually be mindful of our policymakers, so that so it's not only about a population health improvement, but actually improve costs. And then the third, a vital part, is that we need to engage our citizens and our patients. Because at the end of the day, consumerism, in the most positive sense, is going to push us to improve every day. The fact that we use our mobile phone today, that's very different from 10 years ago. It's because of many ways that, you know, the imagination sparked the industry to revolutionize this. And so in the same way for medicine, not only do we need to demonstrate evidence, cost effectiveness, but we really need to partner with our patients and our citizens to deliver the better generation of digital health, improve it and sustain it over time.
Thank you. Would others like to answer that as well?
Maybe just a brief point to say that my feeling, it depends, you know, digital health is very broad, but let's take just telehealth and video consultations. I really think that we've gone too far, and I don't want us to stay at such level of use as we are today. And I say this, like I said before, as an enthusiast. We do need, there are a number of instances where personal touch is very important, where that physical distance really matters. And in that sense, we are at the moment, in many respects, ahead of rigorous evidence for many of the digital health solutions in terms of how we use them, in terms of home monitoring and so on. And we need to rigorously evaluate and find where is that right balance. We were underutilizing before. We are, in my impression, this is a general statement, but for the sake of argument, we are overutilizing it now if the pandemic wasn't there.
That's fair. I mean, I can speak to the US side. One of the biggest fears is that, you know, one barrier that was there before was lack of reimbursement for telehealth. With COVID, telehealth is now being reimbursed, but there is that concern, and nobody knows what will happen. Is that reimbursement might go away again, and then we'll go back to the old levels. I don't know internationally, in other countries and other systems, is that sort of barrier present, or is it truly about, is it just sheerly adoption on the clinical side and on the consumer side?
I think you raise an excellent point in the sense that reimbursement, and just like Prof. Hall mentioned in one of those 3 points, you know, for something to be universally adopted, it truly needs to make economical sense. If it's way too expensive, or if it's not being paid for, even if it has, you know, a lot of benefits, it's going to be a big challenge for that to be adopted, I think. So with no question, you need to, it's something like, that's why you have business models, you know, for a new company. You need to find a way how that's going to be, what is going to be your revenue system and all those things. And so you need to find a way how, we just need to make it economically viable. I think with no question, any sort of digital platform, for the most part, it makes lots of economical sense. I mean, it does. And we just need to find ways, for example, in the US, if it's for reimbursement, it's just for reimbursement. I may be mistaken, but a number of years ago, I think in Canada, It was just identified that you could actually get reimbursed the same if you see a patient in your office versus if you see a patient in, virtually. Well, I mean, most people are going to say, okay, I'm just going to have a virtual office as well. And you increase dramatically the operations and the revenues for yourself. Whereas if in the US, I'm not going to make anything, and then I'm actually going to be liable because someone's going to be video recording my interview with a patient or something. Most chances are that physician is going to say, forget it. I mean, if they want to see me, they come and see me in the office. So it's a little tricky. I do hope, that we will be able to adopt a great degree of all the changes that we have had during the last 12 months.
Yeah. Any other thoughts, again, in your position, if you're able to kind of catch and just keep hold of maybe not this level of telehealth adoption, but just a higher level of go ahead, Dr. Moriyama.
Okay, regarding the doctor-to-doctor education, we can keep on this kind of activities because there should be so many needs, including latent one. So we can keep on doing such kind of medical doctors medical education. But regarding the doctor-to-patient care, there have a lot of barriers, even in Japan. Because as you know, the medical fee is totally subsidized by social health insurance in Japan. But the medical cost for the telemedicine, doctor-to-patient, remote patient care is quite cheap. So then it's very difficult to pay and running cost and also initial cost for the remote patient care. Mm. So that's why then, in Japan, the tele care is still very minor, even under this situation. Most of the doctors use a telephone, not a teleconference system, to take care of the remote patient. It's really a big issue for us.
Right. It sounds like, again, it's sort of that financial, that economic model related to that. Yes, go ahead, Professor.
I'm just going to add a small point. I recognize the cost effectiveness. I recognize the evidence, and absolutely needs to be there. At the end of the day, we need to advocate for equity. We need to advocate for the fact that there are, in many countries, in many locations, that at this point in face-to-face care, that many patients don't get access to care. Now, introducing technology introduce a different kind of barriers. The digital divide leads to some people not be able to access care. But if this virtual care can help us bring better care to bring equity of service, should we not pursue it? So I think, there's remuneration, there's health system, etc. But let's not forget about equity.
Excellent point. And actually, there was a question from the audience along the lines of equity, which is how could telehealth be used to better serve our aging population, both under normal circumstances, but also during COVID, where we know that our seniors are experiencing even more isolation than the rest of the population?
I'm happy to jump in again to start. I think when we think about aging, I think there are several things. One is that, in fact, the young old actually adopt technology much faster. They have the economic means. If they are in middle class or middle upper income class, they have the time to invest, and they have kids that they need to connect with. And so, in fact, adoption of technology is a lot faster. Now, if you get up to 70, 75 and above, then yes, there will be that challenge that we need to be mindful of. Even with that group, though, the technology barriers coming down in terms of interface is no longer typing, is voice, is visual activation. So there are different ways for us to adapt to those type of groups of individuals. However, for the aged with financial challenge, that becomes increasing barrier. And so the more social determinants of health barriers, education, technical literacy, digital health literacy, that introduce more and more layers of challenge. And finally, there's the infrastructure challenge. For example, in British Columbia, if we go out to indigenous communities where it doesn't have high-speed internet, it doesn't have the type of connectivity that we have, again, that limits that. So I think both on an individual level and a system level, for the aged and the seniors, I think it will be depending on the population, but it's a very valid point that we need to be sensitive to the different population that we serve.
Very true. Happy to take comments from others. I did want to, we had a poll that ran, and Brian, if you wanted to share the results of that, or if somebody on the team
I think that's, yeah, no, I think, thank you, Afsana. I think a lot of the questions in the poll were echoing some of the comments. It was actually interesting to me on the results. The first question was, how satisfied are you with the telehealth solutions in your country during COVID-19? It was actually somewhat split. 24% very satisfied, 26% satisfied, 21% neither satisfied nor dissatisfied, and 29% dissatisfied. Nobody very dissatisfied. So it's kind of interesting. It's a little bit flatter than I thought. And the second question, how will the utilization of telehealth solutions change in your country? Increase greatly, 26%, and increased would be 53%, and neither increased nor decreased at 21%. So definitely a positive view there of increase in telehealth. And then in the third question, how has the quality of clinical care changed in your country with telehealth? Much better, 12%, somewhat better, 59%, 26% stayed the same, and only 3% said somewhat worse. So an overall positive view. I think there is the maybe less of a overwhelming satisfaction with current telehealth solutions. So there's definitely room for improvement. I think I would just echo this last question in terms of perception of quality of care to the panel. What is your perception of and I think Professor Carr mentioned this, I believe, in terms of, hoping that there would, we're not removing the personal element of medicine, but how is, to the panel, how is the perception of quality of care changed due to telehealth? Is it improved? Has it stayed the same? Has it, have some parts worsened? Would love your perspective. Maybe Professor Carr, do you want to chime in?
Yeah, I mean, we could have a long discussion. I miss kind of at least seeing the audience, and I'm really a little bit concerned. We are all having clearly fun and discussing topics that we are enthusiastic about. I think satisfaction is great, but it's one fraction, of the whole digital health. And I'll give you an example where, maybe just between us as a panel, we can say, how many of you can book an appointment online with your doctor? And I like to ask these people in different countries, and majority will still say, no, I can't do it online. So it's a very simple thing. It's not even a clinical consultation. It's not even, it's just booking an appointment, and you can do this with a hairdresser, but they can't do it with a doctor. So I'm curious how to accelerate the wide potential of digital health, besides telehealth as a telemedicine and so on. Health apps is one area where, in particular, the decision support software for both patients and clinicians, we could all benefit from more. I don't know what the rest of the panel feel about it.
Any thoughts, Professor Rivas?
Yes, well, there are a number of different things. I think it is true that some of the implementations of digital health have been very limited to basically telemedicine, teleconsulting, doing things over the phone, doing things over video. And I just think most of the stakeholders, especially public and even physicians, they don't really understand the huge capacity and the options that we have with digital health. I think nowadays it comes down to just, can we avoid going to the doctor physically and just seeing the doctor in clinic? So I think we just need to, once again, this is a great opportunity to actually leverage what we have and actually show to the whole community of stakeholders all the different options of things that could be done with digital health. I think that you can bet on a number of things. You can bet on regulators. You can bet on educating people, patients, direct consumer advertisement, doing a number of different things. I think we ourselves have to be a little patient with ourselves. I think we're going fast. Many years ago, it would take a long time for something new to be implemented in clinical practice. And I think this has been a huge step, good or bad, because of the pandemic. But it's been a great opportunity for people like us to actually do something about it. But I still think that it's quite limited. Most people they only see telemedicine or doing simple things, as Prof. Josip just mentioned about booking things online. But there's so many other things that hopefully we can make evident to people, and we can actually utilize. Things with artificial intelligence, robotics, and so on.
Great. Well, I know we're approaching the end. I'll maybe just put one last question out there, since we're all at this event hosted by the International Symposium for Digital Health. So the question is, how can this organization, ISDH, really facilitate the work that you're doing? We know that change can come from a small number of people that have extraordinary passion and commitment and activism, and that's who you are. You're here as clinicians with a passion to move digital health forward. So how can ISDH help in that effort?
And I guess more broadly, how can we increase collaboration on digital health, both with ISDH and beyond?
Please go ahead, Professor Moriyama.
All right. In Japan, and as I mentioned, still such kind of telemedicine is not so popular, but now it's becoming a step by step, mainly on the medical congress. But of course, there should be many latent needs for doctors. But I suppose most of the doctors don't know what we should do for telemedicine, I suppose. That's why I suppose we have to join more to the medical congress and let them know what we are doing and what telemedicine is, what digital health is. I suppose most of especially in Japanese doctors, don't know what digital health is. So I suppose the collaboration with medical congresses are very important, I think.
Great. So education, spreading the word, and collaboration. Sorry, I interrupted somebody.
Please go ahead. Sorry.
I thought someone else was speaking and maybe had some thoughts. Maybe Kendall. We'll leave Kendall with the last word. Professor Ho.
Oh, well, thank you very much. I think there may be two things in addition. I certainly agree with Dr. Moriyama. I think education is going to be vitally important for us, especially as we are looking at academic institutions working together. As research-intense university, we really need to capture that evidence and then translate it into good practice and from good practice, translate into best practice. I think that's another thing that we can do. Innovation comes from community, but what we do, I think, can help as university is to capture those examples of innovation, use rigorous methods to characterize it, and then generate that evidence to support care. And I think the third is, I've been very fortunate to have worked with indigenous communities, and very often they have really innovative stuff. Sometimes we as academic universities, and in fact many of our colleagues coming from very, very reputable universities, we have the opportunity to speak. But I think it's important for us to advocate. It's important for us to not only speak the best evidence, but when it comes time for advocacy for our community, for our individuals, from equity, we should yield our space so that the patients can stand up and then speak to it, so that we all encourage ourselves not only to generate research, education, but we make ourselves a better world. I think that's going to be very important for us to do. And I do want to thank Kelvin and ISDH really generating this wonderful forum for us to have this conversation together, so that not only do we locally can serve our population, but globally we can share this knowledge so that we can advance digital health, serve our patients.
Great. Well, thank you, Professor Ho. Actually, Afsana, I was going to ask you as well, given your commercial perspective on collaboration, both with businesses and academia.
Yeah, I believe that in my efforts, clinicians such as yourself have tremendous influence on the community as well as the organizations. And when physicians champion, physician leaders champion a new technology and a new solution, its adoption is much more successful than when it's not championed by a physician. So I think, just as you're all doing today, if every organization had a person like you that would champion telehealth and really drive its adoption throughout the organization, take that innovative mindset, I really do think that's what it's going to take, near term and long term. And then over time, there will, maybe there are 10 or 50 of you in this symposium, that number will multiply from year to year. And I think that's really what it's going to take. And I don't need to remind you, I think society tells you physicians have a lot of power. Patients will do whatever you tell them to do. So if you tell them to use a digital therapeutic, if you tell them to use telemedicine, they probably will do it. So that's what I would say.
Great.
Excuse me, I want to add a few words. Yeah.
Yes, go ahead.
Yeah, in fact, in the first sessions, we have Ashley from the BMJ Innovations. He also suggests even we can get some involvement in the entrepreneur or some startup company. I think this is a kind of indirect engine to put our connection closer and faster. And today's meeting is very good because we have clinicians, public health expert, some engineer, and also some have mindset of the entrepreneur. I think all are the components that we need to make it faster, to grow faster. And digital health is, maybe we cannot say that digital health is, because someone asked me, what's the difference between health informatics and digital health? I think they are different concepts. Digital health is more fancy and more flexibility among different disciplines. And at the end, the collaborations across the discipline and also the university is very important.
That's a great point. I agree. I think those collaborations can also be very important. I mean, a lot of innovation actually comes out of academic medical centers and then moves into the commercial sphere, the entrepreneurial sphere, because, academic medical centers can't commercialize in the same way. But at the same time, as those companies are trying to commercialize, they go back and try to get the academic medical center to adopt. It's quite difficult. So yeah, those collaborations are very important. I agree.
There has to be a symbiosis with those two, I think, academia and entrepreneurs. That's, I think that would help lead the way.
Very true.
Well, on the note of collaboration and symbiosis, I'd like to really thank all of our panelists and our excellent panel discussion moderator, Afsana Akhter, as well, for joining us today for session 2. And special thanks to the conference organizers, Professor Kelvin Choi, Karen Yu, and Heracles, who have been working behind the scenes and in the front of the scenes, making sure this has been all pulled off very smoothly. I'd like to ask you to fill out a survey about the symposium today. I think they're going to, Heracles may publish it right now, so you can fill that out, to just give us feedback about how this symposium went. And, you know, really special thanks to the attendees for spending their time today, although in somewhat divided time zones across the world. And really, we hope you've enjoyed the talks and discussion today. So I'm going to give some closing remarks, but please fill out the survey about how the conference went today. We are living in a unique time of great adversity and great change. Before COVID, we were slowly and methodically adopting and developing new digital health technologies. At Stanford, and I know, you know, as in most of the world, within a few weeks in the spring, we reacted quickly and converted 100% of all our clinical visits at the time to virtual visits. This has not been a smooth process adopting this new technology, these new technologies. And we may have, echoing Professor Ho's comments, you know, we may have amplified or potentially introduced new inequities and barriers to healthcare access, and while also potentially reducing some barriers. That remains to be seen what digital health has really triggered in terms of healthcare inequality and inequity. However, you know, given the extreme circumstances, I believe technology has enabled and empowered clinicians and patients, and based on the survey, it seems like the audience agrees with that statement. The talks today have shown the future is bright with all the innovators hard at work and all the educators, and really great thanks to Professor Rivas for his great comments and telling us about how his new educational model has really been training the next generation. We're all trying to improve the delivery of healthcare to really improve the health of our fellow global citizens. I hope we can continue our discussions and conversations today to ensure the sustained, continuous improvement of digital tools for health. We hope you will continue to participate in the International Society for Digital Health. You are all, as of today, honorary members. We are not charging any membership, but we hope you will join us next year under the leadership of Professor Choi for our hopefully in-person conference next year, maybe somewhere in the world, possibly in Asia or elsewhere. And really, thank you for your attention today, and please stay safe. Great.
Thank you. Thanks, everyone.
Thank you, everyone.
Bye, everyone.
Bye-bye.
Bye-bye.
Take care.
Bye.
Thanks so much.
Bye-bye.